was
No,
left
I must
here.
collect it
Okay.
from the previous session.
I need to fill it in.
Please, your name and your signature, because it's being recorded.
Can I
Yes,
use
yes.
these pens?
Name with you, Sara?
Eh?
You don't have your own name with you?
No, I'm sorry. But I mean, come on, Krishna,
Ah, okay, fine,
from the
fine.
outside.
Proceed.
5 minutes before.
Where is Babak? I miss Babak.
You miss Babak. You miss Babak. Yeah, can I tell him? I will tell him.
No, I know that you're busy with the new baby.
The baby and many other things.
And the work that Lara is giving him.
Yeah, yeah. To have Babak.
Yeah.
He reacts always. He's very reliable.
Yeah, it's really
We're happy to have him.
from the
Thank you, Ehab, for reminding.
Good afternoon, everyone. Can you hear me?
I have to what? For what is it?
Yes. So welcome to this session on harm reduction and harm reduction interventions in prison. My name is Liesbeth Vandam. I work at the EMCDDA, and I'll be co-chairing this session with my colleague Linda. It's my pleasure to have 5 brilliant speakers on this topic. We will have 5 presentations, and then we'll have a structured debate. And so I'll be asking my speakers in this session to really try to stay within the 15 minutes. This session will address different topics. This will address harm reduction interventions in prison, provision, availability, coverage, models of care, and barriers to implementation. I'd like now to introduce Linda. Linda Montanari is a principal scientist at the EMCDDA. She's coordinating the fields of prison and drugs and gender and drugs at the EMCDDA, and will present for us an overview of harm reduction interventions in prison across Europe. Linda, the floor is yours.
Thank you, Liesbeth. Welcome, everyone. I will present a short overview of the available harm reduction interventions in the European prisons. This information is based on the information that is included in the Prison and Drugs Insight report, which was published in June 2021, and with update that we have received from the European countries in 2022. So I have no conflict of interest. First of all, what the evidence say? I know that there were sessions where this was discussed in detail. In the Insight, we dedicate 1 chapter on available evidence and good practice addressing drug use and drug-related harms in prison settings, where we identify different type of intervention for specific desired outcome. What we found is that the evidence is scarce, but it's scarce because there is little research, little information, and this is why one of the reasons why the ECDC, together with the EMCDDA, published in 2018 public health guidelines on prevention and control of infectious disease in prison setting. But when we look at the different interventions, those where we found more evidence are opioid substitution treatment in prison and test prevention and treatment of infectious diseases. But why this is necessary? So we know that there is a close interlink between drugs and prison. In the map, I don't know if I manage, in the map that you see here is the proportion of people in prison for drug law offenses according to the latest data from the space statistics of the Council of Europe, where you can see that there is the proportion of people in prison for drug law offenses range from 4% to up to 50%, but is a relevant proportion. But also there is a relevant proportion of people in prison with lifetime experience of drug. In this table, it is reported for different drugs, the upper level of prevalence or lifetime prevalence of drug use in the prison population and in the general population. And as you can see, for all drugs, there is an excess, which is particularly relevant, especially for substances like heroin, cocaine, and amphetamine. Also, a relevant proportion of people that are in prison have experience with drug injection. In this graph, it is reported the prevalence of drug injection in 7 countries that are the countries that were reporting data on drug injection among people in prison, in the community, and inside prison. As you can see, in all countries, drug injection in prison, it's lower than the drug injection in the community, but it exists, so it is reported. And we know that this is a risk behavior, in particular in prison setting, where the conditions often have overcrowding, problem of hygiene, and so is particularly dangerous. Also, we know people in prison have poorer health than the people in the general population of the same age, and particularly because of the high level of drug use prevalence for drug-related infectious diseases. In this graph, it is reported the prevalence of HIV and HCV among people who inject drugs and are in prison. And you can see this ranging from almost to 0 in Ireland for HIV to 15% in Spain, and for HCV much higher, but so from 3% in Slovenia to 84% in Greece. But the main information is that there is this issue to be addressed. Another important issue to be addressed is the mortality inside prison. We know that there is a high percentage of people dying for violent deaths, and this is based on a recent French research, and 1 in 10 of those violent deaths are due to intentional or accidental drug overdose or intoxication, and this is something that should be addressed. And the other information that you all know is the high mortality, risk of mortality after prison release, particularly in the first 2 weeks after prison release. So what is this done? In the report that you will find in the internet, in our website, we we try to describe what are the available interventions in prison setting, addressing drug-related problems. And here in this graph, you have the number of countries where the interventions are available. Just yes, no, if they are available officially. And you can see that we go from intervention like infectious disease testing that are available in all countries, reporting information to us, to also information, education, training. OST continue from the communities available in all countries, reporting to us except Slovakia. And then we have intervention reported between 10 and 20 countries, like HCV therapy, testing for tuberculosis, OST initiated in prison. And we go up to interventions that are available only in few countries, like peer interventions, distribution of condom, take-home naloxone, and finally needle and syringe program, only available in 3 countries. But there is a problem not only of availability of the intervention in prison, but there are 2 main issues that should be addressed. One is the delay in introducing the intervention. And in this graph, it is reported the years of intervention or the introduction of opioid substitution treatment in the community, the yellow line, and in prison, the green line. And as you can see, there is a gap in time, in some cases up to 20 years, between the introduction in the community and in prison. The other thing is the coverage. This is based on the result from the HARE-ACT project. And as you can see, this is coverage for HIV and HCV testing in prison. First of all, there are only around half of the countries reporting information on coverage. And when we look at the coverage for HIV testing, there are only 6 countries reporting full coverage, meaning more than 95% of people tested. and for HCV is even less. So there are 3 countries with full coverage. But positive sign, and I'm going towards the conclusion. So we have looked at the information that we published in the Insight, so referring to 2019, and the most recent information now. And here you have the number of countries where the different type of interventions are available. And first of all, there were no decrease in the number of countries implementing the different interventions, but also there was some improvement. So some more countries have introduced overdose prevention and prison release, or have started to introduce the possibility to initiate OST inside prison, vaccination for HBV, and finally OST reinitiated before release. So in order to improve the linkage with the service in the community. This is also a map of the share of the prison population in OST, comparing 2017 and 2021. There were 6 countries that have increased the coverage, 6 that have decreased, so there were some changes, but not always the decrease means a decrease in availability. Like in Spain, for instance, this is more related to changes in the drug use patterns. So to conclude, some final reflection that I hope will be, I think, discussed in the following presentation. I would like to highlight 3 issues. So we know that there is a delay in the introduction of some drug-related harm reduction intervention in prison compared to the community. So it is necessary to speed up the introduction of this intervention, and I think we can take the COVID-19 experience as example, because we know in some countries some interventions were quickly introduced or adapted to the new reality. So it is possible, it is feasible. Second, there is a low coverage and a lack of implementation, so it is necessary really to set up political and practical conditions for the actual implementation of this intervention in prison. What we are doing is to try to identify models of care. There will be a presentation later on this. Implement training for health staff in prison, but I would say also for a security staff, who are the staff, the people in contact every day with the people in prison. And finally, even if we have improved, there is still scarce evidence, lack of data, and lack of comparable data. So it is necessary really to improve the research, to improve and increase monitoring with the use also possibly of comparable tools. So this is the publication if you want to download, and probably we have also some printed publication if you need. Thank you very much.
Thank you very much, Linda, for this very nice overview and introductory presentation. I'm sure you'll have questions, but I suggest you keep them for the end of this session. So now it's my pleasure to introduce to you Laura Iajeva. Laura Iajeva is a public health specialist working at the Department of Public Health and Epidemiology at the Riga Stradiņš University. She will present for us a presentation on hepatitis C and HIV-associated risk factors among people in prison in selected European countries. The floor is yours.
Okay, thank you. Good afternoon, everyone. So yes, I will give you the brief overview of the analysis we performed with colleagues on hepatitis C and HIV-associated determinants among people living in prison. So also the previous speaker emphasized the fact that there is very high concentration of people with drug use disorders and those who are had drug offenses. There is very high percentage of them, and definitely it is the very high risk for bloodborne viral infection transmissions. So yes, there is definitely drug use is much more prevalent in the prison population than just in the general population, and just the global prevalence of HIV in prisons is up to 16%, while the global prevalence for hepatitis C is up to 20%, and actually the majority of the countries are having prevalence of hepatitis C in prison population more than 10%. So yes, you already saw this data, but definitely it's worth to emphasize once again that the prevalence of hepatitis C and HIV in the prison population is extremely high and much more higher than just in the general population. And here the hepatitis C is more prevalent in Finland and HIV in Estonia and Latvia. Several years ago, the project of EQDP, or European questionnaire on drug prevalence in prison settings, was introduced, and during the past years it was developed and updated several times, and definitely due to the fact that drug use and related harm is so prevalent in the prison, it would require also to have this systematic tool for data collection. Other key indicators for drug monitoring are having a lot different systematic tools for data collection, but for the monitoring in the prison population, there was no such tool. But in 2014, so there was this assessment report published, and the results of this report emphasize that there is a substantial heterogeneity in studies methodology, and there is a need to define a common instrument to measure the drug use and related harm in prison population. And as the result, the European questionnaire on drug use among people living in prison was developed, and recently in 2021 it was updated, and now it's already have several versions, long version, short version, and yes. So the data I will present you today is based on this EQDP tool. So the countries are more frequently are starting to use this EQDP tool for data collection in the prison settings. And for the data analysis I will present here today, there is data on 4 countries: Latvia, Lithuania, Spain, and Portugal. So this, also specifically Spain and Portugal, were one of the first countries implementing this EQDP tool for data collection in prisons. So all of the studies are cross-sectional studies, but of course here and there methods of data collection were different, but still it allows us to compare this data because majority of the data was collected with the same survey tool. So aim here was to study HIV and hepatitis C determinants among people living in prisons. So here is the brief overview of the methods of each country. So Spain and Portugal conducted these studies several years ago in 2014 and 2016. Latvia and Lithuania conducted these studies a bit later in 2017 and 18. So almost all of the countries were using this self-administrated approach, except the Spain. Spain had these face-to-face interviews, but also it's increased, probably it also affected the 100% response rate in the Spain, but yes. In Latvia, we were having convenience sampling. Other countries had simple random sampling, and here and there exclusion criteria were different for each of the country, but still it gives us an option to compare this data. So here you can see this self-reported HIV and hepatitis C prevalence among people living in prisons in these 4 countries. And as you can see here, the highest prevalence of both infections is in Latvia. Then Lithuania and Portugal and Spain have a bit lower prevalence based on this EQDP data collection of self-reported data. So here will be just brief overview of the data. So I will emphasize the most important one. So here you can see the multivariate results of demographic factors in association with HIV and HCV. And what was interesting that in Latvia particularly, females had higher odds for HIV, and people who are older than 35 years old had much higher odds for HIV, particularly in Spain. And the same pattern actually here is for hepatitis C, that females in Latvia and older people in Spain. So here are this association with the penitentiary factors like drug-related offense, recidivism of imprisonment. So here what's interesting that actually Spain had lower odds of drug-related lower odds of hepatitis C and HIV among people who were in prison due to the drug-related offense. But definitely the fact, the type of population probably also could define it, but maybe we can leave it for the discussion later. So quite strongly associated with these two viral infections was recidivism of imprisonment. So basically, the more frequently you're coming to prison, the more higher chances you have for HIV and hepatitis C. So some association with injecting behaviors. So strongly associated data was for injection during any imprisonment, so for all of the countries, people who are in prison and were injecting drugs there at least once in their life, they had higher odds of HIV and hepatitis C than the ones who didn't haven't injected drugs in the prison. And also quite strongly associated variable with these viral infections was sharing of syringes, but yes, it's probably quite obvious. So yes, and the last group of variables here is the type of the drugs, and here opioid and amphetamine use were strongly associated with viral infections in all of the countries. Unfortunately, here we didn't have the data for the Spain. But particularly the fact that opioids and amphetamines amphetamine use and opioid use is more prevalent in Baltic states like Latvia and Lithuania, and less prevalent here is the cocaine use. And that is actually opposite for the Portugal. And here for the cocaine use, Portugal had people who are in prison in Portugal had higher odds of HIV and hepatitis C. So here is the brief summary of all of these results, the factors which are increasing the odds of having HIV and hepatitis C. So particularly the most strongly associated factors were recidivism of imprisonment, injection in the imprisonment, sharing syringes, and use of opioids and amphetamines in prison. So definitely these factors should be taken into account, and the identification of these risk factors is quite important for better understanding of the situation and evidence-based action for harm reduction in the prison settings. So that's it. Thank you.
Thank you very much, Laura. Very interesting comparative data sets with focus on risk factors. So now it's my pleasure to introduce Ehab Salah. He's a medical doctor specialized in medical epidemiology at UNODC, coordinating the area of prison health. The floor is yours. He will be presenting for us the international guidance on harm reduction interventions in prison.
Well, thank you, Chair, and thanks for having me to speak about people in prison, a population that has been systematically left behind in the HIV response in many countries, even at the country, regional, or global response. So thanks for having me today. In the coming 15 minutes, I'll go through the current situation, and I would like to start with saying that data I'm using in my presentation has different sources, like the Global AIDS Monitoring, the UNODC Research Trend and Analysis, UNODC High Priority Country Reports, data from the International Center for Prison Studies, related articles and papers on this topic, and so on. So let's start with some data on the prison population. And today, as we speak, at any given day, the total number of people in prison is around 11 million people. However, some experts estimated that the annual prison population can reach up to 30 million people in one calendar year. And this gives us an idea about the high turnover for people in prison that can reach up to 300%, as well as that prisons are not really separated and disconnected from the community. They are all integrated and interlinked, of course. Among the 11 million people in prison, women represent 7%, and the recent data indicated that the total number of women in prison in any given day is 740,000 women and girls in prisons and closed settings. This number recently, because of the COVID-19 measures, like many measures to reduce prison overcrowding, to prevent the transmission of COVID-19, last year it went down by almost 1 million, something like that. It used to be 12 million before. Now we are talking about a number of 11 million at a global level. The incarceration rate, and data indicated that the incarceration rate is around 140 per 100,000 prison population. And again, this is not fixed. As you can see here on my slide, there is a lot of diversity and differences between the different geographical regions. So you can see this is the highest in the Americas, it's kind of low in Africa. So there is a diversity in the incarceration rates. When it comes to prison overcrowding or the capacity or occupancy rate for people in prison, one of the major factors for increasing the transmission of infectious diseases like HIV, TB, and hepatitis, you will see that almost 50% of prisons or countries, they run their prisons at a capacity of 100% or lower, while we have around 30% of the countries in the world, they run their prisons at a capacity between 150%, and while almost 18% of the countries, they have occupancy rate that is higher than 150%. There's around 8 countries in the world, they have capacity or occupancy rate that can reach up to 300%. And this is also tells us about, or remind us of the UN long-standing calls for reducing prison overcrowding and reducing prison population. This is not the thing, but even within the countries, there is some differences, because the country might have an occupancy rate of 100, while within the country, there is also some overcrowded prison. And a good example for this is the central prisons, because in many countries, central prisons are overcrowded because of being close to the court, pretrial detainees, and all of that. So also within the countries, we have some differences. When we talk about the HIV, and according to the recent data we are collecting from our different sources, the prevalence of HIV in prison settings is around 4.3% at a global level. That makes people in prison are 5 times more likely to be living with HIV than adults in the general population. When we talk about the gender, you will see that women might have higher HIV prevalence, which is double those of men. You see that for women, it's much higher. It's about 5.2%, while it's 2.9% for men. Once again, there is some regional differences, some differences in countries where there is a generalized HIV epidemic. You will see that prisons is also part of this generalized epidemic with higher HIV prevalence. Other countries where HIV or high prevalence of people who use drugs or inject drugs, you will also see higher prevalence of HIV in prison settings. It can reach up to 20% prevalence in some countries where people inject drugs are prevalent. When we talk about the total prison population, you will see that 2.5 million people are in prison because of drug-related offenses. This is a big number. And here we can see that 22% of this number is because of drug possession or personal use. Once again, this percentage is higher among women. So women are in prison for drug-related offenses are representing 35% of the women population in prison, while it's only 19% for men as well. When we think about these figures and we think about the limited or absence of non-custodial measures for people who use drugs, alternative to incarceration, limited. When we think about limited access to evidence-based interventions, harm reduction like opioid agonist therapy and needle and syringe program, that might be an issue, that we have people sitting there in prison using drugs or initiating use drugs in prison and services are not available. Not mentioning that the importance of addressing drug overdose prevention and management among the prison population, during their stay in prison and also upon release. Data indicated that people are much higher to suffer from drug-related mortality during the first couple of weeks after release from prison settings. With this in mind, and with all these figures, the global community are committed to work on addressing prison health, ensuring continuity of care, and the principle of equivalence. And we have many documents that's supporting the right for people in prisons to reach good quality healthcare services. I don't have time to go through all of them. I'm just trying to share with you the most recent ones. And of course, the Global AIDS Strategy that has been approved by the UNAIDS Program Coordinating Board is focusing on key populations, including people in prison. The political declaration addressing our ending inequalities, adopted by the United Nations General Assembly last year, and also the ECOSOC resolutions, and most importantly, again, the United Nations Common Position on Incarceration, clearly indicating that prison health should be an integral part of any initiatives for prison reform. One of the most important tools we are using, which we call it the flagship tool for addressing prison health, is the Nelson Mandela Rules, which is the United Nations standard minimum rules for the treatment of prisoners. We have many rules related to health, but I'll focus on only one, Rule 24, indicating that people in prison that should have access to healthcare services equivalent to those provided in the community, free of charge. It's a state responsibility without any discrimination. It also emphasizes that there should be linkages between healthcare services in prison and in the outside community to ensure uninterrupted services for people in prison. With this, UNODC and other UN partners, we have many UN partners like WHO, UNAIDS, UNFPA, ILO, UNDP, we came all together and developed or updated our comprehensive package for services in prison. And as you can see, it's like 15 key interventions. Each of them is effective in reducing the transmission of HIV. However, when you implement all of them together as a package, you will maximize the benefit of this. And of course, you will see many of these interventions are related to harm reduction services, including opioid agonist therapy, needle and syringe programs, and also prevention and management of drug-related overdose. It's available on our website. However, the situation in countries might be a bit different because you will see the coverage of healthcare services in prison. It's not everywhere. Let me start with talking about needle and syringe programs. As you can see, this is the data we collected last year. And needles are only available in 9 countries. All of them are in Europe, Central Asia, and Canada. And many of the geographical regions, they don't have needles in prison. While opiate agonist therapy is only available in 95 countries, this data is also available recently by the Global State of Harm Reduction report published by our colleagues in Harm Reduction International. It's like even very close to this data. You will see that this is the services available in prison setting, and it's far beyond our targets, and also there is definitely no equivalence to those provided in the community. Our key message here, as you can see, is focusing more on how to move forward and how to work together to address issues related to harm reduction and other services for people in prison. And let's agree that the healthcare service in prison is always jeopardized by the funding, also over-reliance on external funding, and also affected by crises, whether health crises like COVID-19, conflicts, post-conflicts, and natural disasters as well. So this is why we always say that healthcare service in prison, in some countries it's fragile and is always under the threat. Let's also make sure that the lack of linkages between healthcare and community services in prison and outside prison, this will lead to the interrupted services. And this is, we lose the gains that we have been working together. So we need to work together to ensure that there is a political will at the country level, and ensure that we develop appropriate strategies, ensuring that health in prison are provided in a quality and good coverage as well for all people in prison settings. And the other thing is we also need to develop strategies to ensure that these non-custodial measures are there, alternative to incarcerations are implemented among people in prison. Funding is also an issue, and we need to promote funding, whether external or internal funding, domestic funding, this is also very important. Resources, including human resources, we need to work together to ensure that people in prison, they have enough and well-trained healthcare providers as well. Data and strategic information is very important, and we promote that we need to collect systematic collection of data and also the development of sound monitoring and evaluation system. Working with CSOs is lacking in some countries, and I would like to stress the importance of the meaningful engagement of civil society organizations when we work on prisons and prison health as well. This is some of our publications. Please visit our website. Many of them are available there. And maybe I'll stop my presentation here. Thank you very much once again for having me, and have a good evening. Thank you.
Thank you so much, Ehab, for this great talk.
So we move on to the next presenter is Heino Stöver, one of the most well-known experts in prison and drugs. Heino is a social scientist, professor of social scientific addiction research at the Frankfurt University of Applied Science in Germany. He has many years of experience in addiction care and prevention, health research, national and international project management in areas of prison health, HIV/AIDS, gender and health care for marginalized people. Heino will talk about the impact, role and prevalence of medication-assisted treatment for opioid users in European prison. Heino.
Many thanks, Linda, for the kind introduction. I would like to speak to you about opiate agonist treatment or opiate substitution treatment. I will not, let's say, be very specific on the wording, but I will substitute it by the wording itself. We will go a little bit deeper into the prevalence of opiate substitution treatment, of the impact and evidences, and also I come from the same angle as Ehab, my speaker before, coming back to the comprehensive package for HIV prevention. And again, here you see that one of the most important targets is here the opiate substitution treatment. This is the updated version from 2020, and in the earlier one, it has only been stated that drug treatment is one of the key approaches within this comprehensive package of 15 key interventions, but it's more precise that it is opiate substitution treatment. And this is because there's a lot of evidence for this opiate substitution treatment, which has been reflected also in the most recent paper from the UNODC. And here again, OAT is mentioned very deeply. It's important for the initiation, continuation of OAT in prison and other closed setting. Very important in these settings. It supports people with opioid dependence to access treatment and avoid withdrawal. And finally, there's a linkage necessary between prison and OAT services in the community settings that can improve continuity of opiate agonist treatment and reduce recidivism. That's very important, and we all know that there's a lot of evidence for this kind of opiate or treatment for opiate use disorder, which is now the number one treatment, I would call it, and I put it here together in this slide, and I would only highlight a few out of them. And one definitely is that there's a huge cohort study. Sara Mazzilli, for instance, from Australia, said that being an OST in prisons is associated to a high degree with lower hazard of dying in prison. It's being associated with a lower hazard of unnatural death. It's associated with all-cause mortality, and finally with a lower hazard of unnatural death during the first week of incarceration. So lots of data on that. Dagmar Hedrich and others already very early associated OST or analyzed the OST treatment with the spread of infectious diseases and heroin use. It reduces heroin to a very high degree. It increases in-treatment entry and retention after release. And of course, for post-release reduction, there we see a reduction in post-release, we see a reduction in heroin use and many other positive results. However, a disruption of continuity of treatment, especially due to brief periods of imprisonment, is associated with very significant increases in hepatitis C incidences. So continuity is the A and O of this kind of treatment. And also John Marston, who is the winner of the prize of the European Addiction Research this year, he made a very important, and colleagues, a very important study. Does exposure to opioid substitution treatment in prison reduce the risk of death after release? A national prospective observational study in England with a huge sample of participants, 15,000 divided in half exposed to OST and half not exposed to OST, and the results were very, very convincing that it led staying in methadone or buprenorphine treatment is a highly effective means of reducing the risk of death by 75% reduction among people in the first weeks after release in prison. And this is very important. And when we look at the acute risk of drug-related death among newly released prisoners in England and Wales, we see that especially women are facing a tremendously high risk of overdosing in the first week after release, but also men are quite vulnerable in this period of time. But looking at the, let's say, global coverage in the availability of OST in the community and in the prison, we see here from the global state of harm reduction, this slide, the light green is everywhere where OAT is available in the community, and the dark green in the community and in prison. And we see here that there's much to do, let's say, to keep it all in dark green. So there are many problems of implementation I would like to focus on a little bit. First of all, there's an inequality compared with the civil sector, for sure. There's a percent of prisoners receiving OST increasing, but still low in many countries, rarely associated with psychosocial interventions, variable doses within the same country, within the same state, and even within the same prison, and the lack of formal guidelines, therapeutic recommendations, and the current delivery of OST in prisons shows inconsistencies and is often carried out in isolation from routine clinical assessments. There's a lot of problems we can focus on, but especially we evaluated in a scoping review on the implementation of OST in the criminal justice settings. There's a lot of pervasive, multi-leveled and interdependent problems across correctional and community settings, a disruption to the management of addiction and reduced treatment choice for OST adversely influences inadequate prevention of OST in prisons, and especially the following populations are especially vulnerable: older people with comorbidities and complex treatment needs, women who have experienced trauma and have childcare issues, and those with existing mental health needs requiring effective understanding and treatment in prison. However, there are many barriers to overcome. First of all, I think in many prison jurisdictions we see an abstinence orientation, which is predominant concept for any treatment of drug use disorder. We do have we're facing juridical concerns, a lack of knowledge within the prison system, many doctors, also nurses and authorities, also a lack of infrastructure and mixing up OST medications, or the OST methadone and others with street drugs by staff and medical doctors, political reasons we were facing, and I would like to focus a little bit in the last slides on how to overcome these obstacles of inadequate implementation. First of all, what we did a long time ago, and which has been updated several times, we did a practical guide with the help of UNODC and WHO on opioid substitution treatment, which has been translated and adopted into many languages. However, what we need is more concrete, let's say on a national or even regional level, therapy recommendations, protocols, and MOUs, Memorandum of Understanding, in order to establish a clear OST strategy between care team and prisoner at the moment of arrival, noting the individual specific needs, ensure that OST is prompt, reliable, and adjustable, establish clear protocols for transition to the community on release with no gaps in care and no changes, and with adequate safeguards against overdose, and finally integrate clinical and psychosocial care using a full team care plan that regards the prisoner as part of the team. So that's what we think about. Overdose and diversion, definitely there's a risk of overdose, but that can be minimized, as I showed, by proper anamnesis, including information by a treating doctor outside. Start low, go slow, that's the slogan. Dosing needs to be done individually, adjusted individually. Of course, identity, supervision of intake, many ways to prevent diversion. And what is new, and which is specifically suitable for the prison context or closed settings context, is long-acting medications available that reduce stigma and that are offering that can be associated also with psychosocial care. People do not have to show up every day, which is definitely a stigmatizing process, that everybody will know that you are in the OST program. But also we should make use of different medications available and authorized and registered in the community. That is not the case in many countries where, let's say, one-size-fits-all strategies are being applied, like methadone for all, and switch from buprenorphine to methadone because of, let's say, cost reasons or whatever. Personalization of treatment means that we are adjusting to the personal needs, the medication and the dosages which are required, which are needed, and we see that we need to manualize treatment. We have to have specific protocols that are transparent for all the people in order to overcome the barriers. And what I followed quite a lot of times in countries is that a consensus statement, for instance, is very important, which gives a clear background paper and is mentioning and regulating the key aspects of OST, like uninterrupted treatment and custody, integrated with psychosocial care, and clear plans for what happens on release. I know that from my own country that, let's say, these protocols were the reasons to increase the availability of OST within 10 years from 8% to 40% in one of the population, one of the lands, the states of Germany. So that is of utmost importance. But also educational needs need to be covered. We did that with e-learning courses on the example of Moldova. Inform all staff members. It should be a clear understanding of what OST is as a medical professional treatment, and it's not a gift, it's not let's say a reward for well-being, but it is a necessary treatment for people who are suffering from substance use, from opioid use disorder, and therefore we should educate and train people, but also prisoners. Involving doctors and NGOs from the community is quite important. It has turned out to be very successful, but also involve people living in prisons, prisoners themselves, continuity of OST after release. And what I find of utmost importance is a quality management. We saw that a lot of countries here are offering OST, but looking a little bit deeper into it, we see that the quality often is quite poor and the prevalence is patchy. And so we have to look at the availability in our countries of OST, the efficiency of OST service in general, recent trends in prison OST provision, and the extent of user-prisoner choice around substance maintenance or withdrawal and the dosage. So we need to ask ourselves and the service delivery, what are the practicalities in terms of choice and diversion of medication? What are the challenges facing OST programs? What are the important features and best practices in OST provision? And is there an alternate date dosing possible? And injecting behaviors need to be kept in mind. We know and have a lot of data on that. So finally, let's go for, let's say, the topics to be tackled in each and every prison system: the initiation of OST, the continuation or the uptake of OST shortly before release. Is it integrated in clinical and psychosocial care? Is it covering diverse prison population needs? Is it tailored to them? Is it looking at older offender, mentally ill people, women, ethnic and cultural minority populations? And finally, I would like to argue strongly to combine it with take-home naloxone. We did some studies on that, and it turned out to be rather successful. So to conclude, in the end, prison-based OST is a highly effective means of treating opioid use disorder. It is the starting point and stable therapy for treating other disorders and infectious diseases especially. It's highly effective of reducing the risk of death among people in the first weeks after release. We should apply to the principle of equivalence and continuity of care. That should be the guiding argument, and it should be combined with take-home naloxone. Many thanks for your attention. Thanks a lot.
Thank you very much, Heino, for taking to some more practical also intervention. Now the following intervention is on harm reduction intervention in viral hepatitis elimination in prison. We should have had Lara Tavosky from the University of Pisa, but for health reasons she cannot be here. So Sara Mazzilli will present this. Sara is a biologist in Master in Public Health. She is PhD student in data science. Her research aims at highlighting data gaps that hinder the analysis of the pandemic's impact on particularly fragile and vulnerable populations, including people living in prison. She's been working since 2021 as a visitor at the EMCDDA. Sara.
Yes, thank you, Linda, for the nice introduction. Good afternoon, everybody. Yes, today I will present the result of this project that on behalf of Lara Taboschi, but also of the research group made up of the research group at the University of Pisa with Luca Ceccarelli and Lara, and the responsible at the EMCDDA, Linda and Thomas Eiler, that is among us sitting in the... Okay, so we all know that the WHO set the goal of hepatitis elimination by 2030, and we know that the prospect of hepatitis elimination is challenging because of the scale, of the complexity, and also of the cost of implementation. A more pragmatic approach is to break down this national and global elimination goal into smaller goals for individual population segments. To apply the so-called micro-elimination approach that constitutes a method to take small but tangible steps toward the larger goal of eliminating hepatitis in the entire population. And we have extensively saw with the previous presentation now that people living in prison have a higher risk of acquiring hepatitis. You already saw this graph. And that, unfortunately, the evidence shows that activities to prevent and treat hepatitis are often not fully implemented in prison, and the coverage of this intervention is often suboptimal in many countries. So we want to, with our project, we wanted to identify model of care to prevent and control viral hepatitis among people living in prison. And in order to do that, we set up an advisory board with prison experts. Some of them are here today. We asked them an help to identify prisons where hepatitis elimination activities were carried out. Then we sent an exploratory questionnaire to the prison identified to collect information on activities implemented in prison regarding viral hepatitis elimination, of course. After that, thanks to the information gathered through the survey and with the support of the advisory board, we selected 5 prisons, the one listed in this slide, and for each of these prisons, we decided to explore one aspect of the hepatitis prevention and control pathway by conducting some semi-structured interview with the doctor working in those prisons. And these are the characteristics of the prison we selected. We have from low to high security prison. We have prisons that are only male, only female, and also mixed prison. And they are quite heterogeneous. But starting with describing the model of care, we start with a prison in Spain, in Ocaña, where they have a comprehensive harm reduction package for drug users. The model of care is built around 4 main activities. First of all, they have a lot of measures put in place to prevent drunk from entering prison. Then they offer substitutive therapy with a person-centered approach. What does it mean? It means that there is a multidisciplinary team of professionals with a medical doctor, nurses, psychologists, social worker, and even a lawyer, and that meet periodically to discuss about each patient need. Then they provide health education before the start of the treatment, to inform the patient what to expect from the treatment, which are the possible adverse reactions. And they also offer counseling with psychological treatment and social support. And this activity is carried out by an NGO that followed patients within the prison, but also after the release. Then for the prison in Italy, in Milan, we focused on the vaccination for hepatitis A and B, and they were offering the vaccine both to people living in prison, but also to the prison staff. They were offering the vaccine for people living in prison at entry during the medical checkup, and they organized also vaccination day for the people living in prison that in the beginning refused the vaccination to increase the coverage. They offer health education intervention tailored both for people living in prison and for prison staff. And practically before the vaccine administration, usually a nurse does the antibody test, and then if the tests are negative, the first dose is administered, and during the same visit, the second dose is scheduled. If the person is expected to be released before 6 months, the rapid schedule for hepatitis B is applied. At the beginning, the prison staff was reluctant to be vaccinated in the same setting and in the same session with people living in prison, so they have to organize different settings in a different room dedicated for this population. Then we interviewed a medical doctor working in Luxembourg, and we focused on the service to prevent infection transmission within the prison. They were offering the screening test to all the new arrivals with an opt-out option, but they were able to have a really high coverage, around the 90% of the new arrivals. If the screening test was positive, they were doing the PCR, and if the PCR result was positive, within 2 weeks from this result, the person living in prison was provided with a specific diagnostic pathway with fibroscan, blood examination, and also a visit from an infectious disease specialist. In order to keep high the adherence to the treatment after the release, they were provided the treatment to the harm reduction services, where people usually go for substitutive therapy, for needle and syringe program. And to the people who have not a place where to stay after release, they provide housing in a place that was very close to the community services. Then we interview a doctor working in a female prison in Berlin to understand the specific need of female in the hepatitis care. And actually, the medical doctor was a female, and we think that this was relevant for the activity, for the organization of the activity, and for understanding the need of this really fragile population. And the doctor said that she was able to organize women-oriented healthcare service in prison because she had a large number of women. And the most important thing she was reporting, that she mentioned that really important for her was the training for the staff, from the prison staff and for also the healthcare worker, to let them understand the specific vulnerability of women living in prison that we know have often an history of violence, of drug use, of prostitution, and so she was explaining why the hepatitis care was so important for this specific population. And last but not least, we interview Fadi, that is here among us, for his prison in Montpellier, and we focus on the continuity of care and treatment after release. Actually, in France, the medical records registered in the health information system within the prison, it's the same, are directly transferred in the one used in the community. The system is the same. And Fadi told us that in preparation for release, a doctor and a social worker would meet the patient to set up the most effective step for the continuation of treatment and care also outside prison. And if it was appropriate for them, they were providing the necessary medication to complete the treatment course outside prison. So in this analysis of model of care, we identified some common overall barriers and facilitators. we saw many doctors were mentioning that prison staff and healthcare workers had a negative attitude toward people living in prison, and they have had a lack of knowledge of hepatitis care. And for this reason, they were providing education activity targeting both people living in prison staff, healthcare workers working in prison. They also mentioned a lack of leadership and allocation of responsibility. Indeed, what we saw is this model of care were so well implemented because there were people really motivated to do it, with the will to do it, as Fadi that is here among us. And that was the difference, what makes this model of care work. They also mentioned a lack of human resources and high turnover of healthcare workers. But they were also often mentioning that they were doing task shifting, giving responsibility of the program to nurses that were specifically trained to do it. Really a challenge that we already listened in the presentation before was the continuity of care after release, especially for foreigners people. And for this, they were trying to collaborate with the different health services, also outside prison, with harm reduction services, and also with the NGO that can follow the patient inside and outside the prison. They mentioned also that the data transferability was a problem because often the information system in prison is not the same as used in the community. And in general, we observed that they mentioned a lack of a strategy, a plan, some guidance for the elimination of hepatitis in prison. And with this, thank you for your attention.
Thank you very much, Sara, to present the result of this project that you are doing with my colleagues Thomas Saylor and the University of Pisa. I think we have time for some questions before I give the floor to the discussants. Is there any question?
Hi there, thank you for a series of really interesting talks. My name is my name is Brad Hillier. I'm a consultant forensic psychiatrist in the UK and an addiction psychiatrist. I used to work in Wandsworth Prison, which is one of the largest prisons in the UK for mental health in reach and in addictions. It's a question for Ehab, and it's really asking in the sort of the 15 interventions or plans. It was mentioned that the people with mental health problems in prisons are obviously a particularly vulnerable group, but there was nothing specifically in that plan to talk about developing mental health services in prison. I know it's inferred, but not explicitly stated. I was wondering why that was.
Yeah, please.
Thank you very much for your question. And yeah, very, very valid point. And unfortunately, I was allowed to speak for 15 minutes, and definitely this is not enough to cover many topics. Yes, the comprehensive package, the one I showed there, it doesn't say mental health, but the document itself, it's talking about mental health and support, psychosocial support, and mental health to provide mental health care services. So definitely, it's part of the comprehensive package to address health, HIV, and other health-related topics in prison settings. So it's already there and mentioned, definitely. But thanks for flagging this out.
Thank you. Other? Then maybe I have a question for Heino. You say that there are some groups for which there is particular concern, and what, like women, mentally ill, ethnic minorities, and what do you think we can do to improve the intervention, the harm reduction intervention for these groups?
You mean general harm reduction measures? Okay. Yeah, I think the answer is we have to do several steps, several approaches on several levels. my profession definitely is from the research point of view. We can carry out studies which are convincing, which are giving the practitioners, let's say, a background, a justification of introducing harm reduction. There's a lot of, a bulk of evidence, meanwhile, collected internationally for needle exchange, for opiate agonist treatment, for condom provision, and many other things. However, these things mostly remain on the shelf of science and academia. I think we have to, we as researchers, we have to make up our minds to really bring that into practice. Just one example, what we did earlier is we had a huge study on the coverage of of condom and the availability of condoms in prisons. This is nothing for the shelf, so we organized a condom summit in Frankfurt in 2020, something like that, and to really, let's say, check how countries are offering condoms within the prison system and how to improve it and to also integrate former prisoners. And finally, within the European project, we did a pilot then in a Prague prison to install condom automats in the male toilets of the prisoners there. So this is something I think we have to more keep in mind, to bring our results not only to peer-reviewed journals, but also, let's say, into the real practice and to the people who are finally deciding on how and what to implement. I think this is, from the researcher's point of view, something we have to do. However, there are many, let's say, groups of former prisoners of drug use themselves who could scandalize certain situations, certain conditions, as we saw here, the lack of availability and coverage in many harm reduction issues. So they could scandalize, and they do already with a certain success, however, the reduce and the lack of certain harm reduction service. That's something ongoing. But you mentioned, Linda, there's a small progress in, let's say, introduction of harm reduction measures, but it's going too slow with regard to the spread of infectious diseases. So we have to speed up and make up our minds on what can all we do on different levels.
Thank you, Heino. Yes, Ehab?
Can I add to this, please?
Yes.
Thank you very much. And yeah, very, very good point, Linda. And of course, I fully agree with what Heino just said, and especially when it comes to the tools and commitment and all of that, it's all there. And we have all of these things available right now. And again, there's many, many tools that are already available. I'm talking about the right to health for people in prison settings, more than what I presented. And recently also our colleagues in WHO recently published the consolidated guidelines for key populations, including for people in prison as one of the key populations as well. We are working together again to develop some more policy briefs in this regard. So we have tools and it's already there. However, we need to work together for strong advocacy efforts, and we need to collect data from the countries who has these services to start advocacy effort to convince decision makers and parliamentarians. Heino mentioned in his presentation that even if the service is available, the coverage is a problem, because what I presented is the country is considered providing needles or opiate agonist therapy if the country has only one site. This means that the coverage at the country level might not be at the same level. In some cases, you can find harm reduction services provided in one country, one prison only, and still counted as yes, but the coverage is there. Quality is always a question mark. So I think we need to work together for strong advocacy efforts and build a case to make sure that people in prison, they have access to quality harm reduction services.
Thank you, Ab. Just to add on what Heino was saying, so I presented this small progress, but it's just the number of countries implementing this intervention. So we don't know yet, but we are implementing instruments to collect more data on coverage, on the quality of the treatment, on the specific interventions that are provided, and we have an ongoing other instrument to be implemented in different countries. Annette, I see.
Thank you very much, and thank you all for really good presentations. I'm Annette Verster from WHO. Ehab, you already mentioned our recent guidelines and that we're working on presenting the package that you have with the 15 and our package, and to make this consistent, etc. So one of the things I wanted to highlight is also the need for more access to condoms, because that's almost worse, that situation is almost worse than OAT in prisons. And also PrEP, pre-exposure prophylaxis, which really for prisoners could be an interesting prevention opportunity. Thanks.
Thank you. I don't know if you have any comment on this. Thank you for your comment. Any other question from the audience? Yes, please.
Thank you so much for this interesting topic. And I'm a psychiatrist from Kazakhstan, and I'm dealing mostly on my time, professional time, with people who suffer from NPS addictions, new psychoactive substances. And it's really rising trends in our Central Asia region. And considering this, I have a question about what could be recommended in addition to these main packages for harm reduction, considering this trend. And we have to be proactive in prison for NPS using prisoners, people, what could be done in this direction, especially on evidence-based nature. Thank you.
Thanks, Maria, for this question. And indeed, we see a growing prevalence, a growing spread of new psychoactive substances also in prison. There has been a European project, especially on that topic, on NPS in prison. What we got out from that is that on the one side, there's a lot of efforts to control the influx, the income of NPS in prisons, which is a very demanding and very ambitious approach. But this needs to be done anyway in prison context. The other thing is on how we could react on NPS use, because there's no, let's say, evidence-based approach to designed to specifically NPS use. What we did in this project was, let's say, with the integration of prisoners' voices and views, to follow the consumption of NPS itself, and then to educate people about the, let's say, the devastating and uncalculable effects of NPS, whether it comes to synthetic opioids or synthetic cannabinoids. And this has had a certain effect, at least, though, that we let prisoners themselves on a peer-driven intervention level or peer-to-peer level, that we let prisoners themselves describe the effects to other prisoners, and that was of a certain extent, to a certain extent, successful from the few prisons we had in our sample in Europe. But there's no general answer to that. It's a very important question, Maria, but we have to spend more efforts, research effort on that.
Yeah, and if I may add, also in 2018, we published a report on NPS use in prison, where there is also a section where we describe what is done at European level. I know that the UK, they've produced a toolkit for intervention in prison for the use of NPS. Yes. Okay, we can take the last question, and then we go to the final discussion, if there is any question. So if not, then I would like to invite Fadi Meroueh and Filipa Alves Costa for some final discussion points. Fadi Meroueh is currently a hospital practitioner and head of the health unit of the Villeneuve-les-Maguelons prison in Montpellier. He is vice president of MENARA and is also the president of Health Without Barriers. They had a meeting on Monday of the Health Without Barriers Federation. He has contributed to the eradication of hepatitis C within prison of the Villeneuve-les-Maguelons. Filipa Alves da Costa is a specialist in public health and health policy, working for the Alcohol, Illicit Drugs and Prison Health Program at the WHO European Office for Prevention and Control of Non-Communicable Disease with Karina Ferreira Borges. And I think they have prepared together some final point for conclusion and discussion. Thank you. Filipa, the floor is yours.
Thank you, Linda, and congratulations on organizing this session. We have really enjoyed it. To some extent, our intervention now is a bit redundant because all has been said and discussed. So what we were asked to do is basically a short wrap-up and overview of the main points that were presented in this sequence of talks, and then reflect a little bit on the barriers and how they could be overcome. So starting with what has been said, I will not repeat it all, of course, but I would like to highlight perhaps the first findings that were presented by Linda on the availability of the interventions that exist in Europe, which showed us that there are some interventions that are much easier to implement, and others are still lacking and falling behind. And this data has also been complemented, and this has been referred by other speakers, by data that was presented in other sessions of the Congress, namely by Harm Reduction International, which presents a global picture. And again, it shows the same, that harm reduction interventions in prisons are hard to implement for a variety of reasons. But a point that was now just issued in the discussion, it's not so much the availability, but also the coverage. So this data just points a country, and it's indicating that it has the service, but it can be one prison in 200. So it doesn't really mean anything. And the opposite is also true. So there are countries that are not represented in Harm Reduction International findings, for example, and which are present, in fact, in at least one prison, like Fadi's prison, which is not reflected in that report. And that is because that is not acknowledged by the French government, so it doesn't exist. So the quality of data is an issue here. So we all resort to different data sources. Sometimes we rely quite a lot on self-reports, and of course there's social desirability associated with these reports. Another aspect I think that has been raised by Professor Stöver was the quality of service. So he focused quite a lot on the person-centered approach, but I would also like to bring another point, which is the access to essential medicines, which sometimes in many parts of the world is not being respected in the general community, so even worse in prisons. The different models of care that have been presented clearly show that there are success ways of doing this. And again, I'll refer to Fadi's prison with the example of microelimination of HCV, which seems to be an easy way to do it, and taking prisons as a place where we can give people opportunities to have access to care. I think Ehab talked quite a lot about all the international guidance that exists, and that clearly shows that there is evidence that these interventions are effective, so we cannot keep saying that it's not implemented because there's no evidence. Annette also referred to the guidance that was recently launched by WHO, which complements this. It even has some additional interventions, and although it's focusing on 5 key populations, the one population that has the widest range of interventions that are considered to be a priority for implementation in prisons is the prison population, of course. It's important to then reflect on the barriers. And some of them have been presented, but we thought of 4 main barriers. Perhaps you can think of more. So the first would be the security and legal issues, which are probably the ones that are most linked to the needle and syringe program. But also cultural aspects, because of course the implementation of these programs means that there is a recognition that there is drug inside prison. Another aspect that's really important is the limited funding. So this, of course, limits the ability to implement the full package that's recommended. And if we focus on this recent WHO guidance, there's also one conditional recommendation that's being provided there, which is increasing the frequency of HCV testing. And that will make it even worse because it requires more funding, as in many countries where it is made, it's currently done on an annual basis. So the third barrier is cultural beliefs and misconceptions. And these misconceptions relate above all to the fact that many people think that people that are put in prison stay there forever. So Ehab has also shown that that's not true. We have a report shortly coming up, which is the Health in Prisons European Database survey, so the status report. And again, in this report, we show that the average length of incarceration in the European region is below 2 years. So this obviously shows that people who are in prison will return to the community. So this brings us to our fourth barrier, which is the fact that although there is evidence of cost-effective interventions, there is not so much evidence that these interventions bring savings to the community. So basically the community dividend. So showing the society that if we invest in people in prison, that will bring benefits also to the society at large. So just to conclude, I think I would like to say that, as you probably all know, WHO has been advocating for the Ministries of Health to take the leadership for the provision of healthcare in prison for quite a few years, but this is still not widely implemented, not even in Europe and even less in the rest of the world. But the truth is that in that area, there is not so much evidence that these models of governance do result in better healthcare provision. So perhaps a point for discussion would be the extent to which we should consider also involving other ministries, like science and technology, because they should be promoting, for example, evidence-informed policies. And if the evidence is there, then somebody needs to do something to make them reach the field. So thank you.
So thank you very much, Filipa and Fadi, for this final conclusion. I would like to thank everybody for participating. I think there is some little progress, but it's important to highlight and to make this issue, which is very important, visible, to have more evidence, as we say, and also to move to the practice and to the implementation of the intervention. So thank you to everybody. Thank you to all the speakers and Liesbeth, the chair. And I think we have now the final session here. Thank you.